assume nothing and listen to the patient. I think, again, like I come in with my, big doctor brain, and like I've been treating eating disorders for 20 years. Here's the deal. But when I come in with a beginner's mind, and I can be present in the room with another human being, and I can listen to them, I learn a lot from them. And I learn a lot about my own bias. That doesn't happen if I go in and I'm like, I'm the doctor, I'm an eating disorder specialist, and here's the deal. Practice humility. How often are we saying to people, yeah, it's complicated. We don't know yet, Or we don't know for you. Knowing what I know for you over the last, X amount of years or X amount of months, here would be some of my concerns. Do you have any of things? What are your hopes? What are your motives? All of that, And we need to also, like, this is something that drives me crazy in medicine. It's so fragmented, right? So my patient may go to a GI specialist and be put on, or be told, like, you know what, I think you have you have overgrowth in your small bowel. Don't eat any sugar. In fact, don't eat any carbs. Your BMI is like 18, so you're doing great. But when we know what a patient has, all of the things, including their medical diagnosis, their eating disorder diagnosis, when I'm talking to them about a treatment, I take into account more than just that treatment's effect on the eating disorder. I also must take into account, well, what's my treatment? Because I'm laser focused on this eating disorder. What impact is that going to have on their coronary artery disease? What impact is that going to have on their type 2 diabetes? What impact is that going to have on their depression? You get what I'm saying, right? So what do we do when there's a limited direct evidence base? In the words of a wise mentor of mine, Tim Brewerton, we rely on the three-legged stool, right? So established evidence base for relevant similar conditions. Are there any evidence-based treatments that work for things that are similar to this, or things that might be similar to this? We rely on our own clinical experience and expertise, which again is inherently limited and biased. I have not treated every patient with an eating disorder, or every patient with addiction, or every patient with a million other psychiatric diagnoses. And last, but far too often, either not listened to or discounted or pathologized. We do a lot of like, that's your eating disorder talking, right? Patient values and patient preferences, and that must be individualized.